Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is part one of a 12-part series entitled COVID-19 Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 diagnosis and management, each followed by a question and answer session designed to address infectious disease specialists' most pressing COVID-19 questions. During this podcast, Dr. Vikram Mukherjee from New York City will provide a short update on the latest COVID-19 incidence trends, the role of serology in disease assessment, and newly published data on evidence-based antiviral therapy for severe COVID-19 disease. For more information on Dr. Mukherjee and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear a brief COVID-19 update and answers to clinician questions by Dr. Mukherjee.
Hi, everybody. My name is Vikram, and I'm a critical care physician based out of New York City and work in the Bellevue ICU. Bellevue Hospital is a public hospital and was part of the surge that New York City saw. And I'd like to share some of the experiences that we saw here over the last few months and go over any questions that we might have towards the end of this talk. Thank you for coming, and I look forward to have an exciting session with you. So as you probably know, over the last 5 months or so, the world has gone over a major upheaval based on this new pandemic, on the SARS-CoV-2 virus. The most recent numbers, as you can see on the slide, and these numbers are evolving very quickly, show that there's more than 5.5 million patients who've been infected, known infections with COVID-19, more than 350,000 deaths. And these are known deaths based on testing. I can assure you that a large number of patients have died either from COVID undiagnosed or because of poorer access to healthcare, since hospitals in many parts of the world have been overwhelmed with the pandemic. In the US, more than 1.7 million cases, more than 100,000 deaths attributed to COVID-19, a very sobering figure. And New York City, as you know, has been the epicenter of this outbreak in the United States. Thankfully, at least for the first wave, things look to be improving. As you can see here, these are the 5-day moving averages of daily confirmed new cases. And as you can see here, most of the trends, the 5-day averages in new cases are coming down nicely. Of course, these are in places that have seen a huge surge in the first wave, and there are other places in the world, in Southeast Asia, in parts of Africa, which haven't seen their first wave yet, and numbers there, slopes there are still climbing. I would urge you to interpret this graph with a bit of caution. Knowing that history repeats itself, we should learn from our 1918 influenza pandemic, where the second wave affected and killed way more patients than the first wave did. And we need to be cautious in how we continue or stop our social distancing, interpret our antibody results, which we'll come to in a little bit. But for this first wave, at least, I'm happy to show you that the numbers are coming down fairly nicely, and we have similar experiences in the ICU where there is a sense of normalcy returning slowly to our daily workflow. A few questions. So as we broach upon these antibodies, the first question that I'd like to highlight and show some data about is the question that we often get at the bedside: do the antibody tests have a role in diagnosis? So going over the basic antibodies, there are 4 of them that can be used. 3 of them are approved in the US, the 4th in Singapore. The first one is a rapid diagnostic test. It has a decent sensitivity of close to 90 to 99%, and it tells us the presence of antiviral antibodies. The second one is a conventional ELISA test. It takes a little bit longer. Sensitivity depends on when you're testing the patient post-exposure, and again tells us in a quantitative way whether the patient has antibodies or not. The third one, neutralization assays, is not available in the US, but is available in other parts of the world, mostly in Singapore. And the last one is a chemiluminescent immunoassay with varying degrees of sensitivity as well. Now, as most of you know, antibodies take a little bit of time to form and has a lot of host immune system responds to affected. So if you look at this graph, for example, if, for example, a patient gets infected on day 0, the conventional incubation period, from what the data suggests now, is between 2 and 14 days. You have a huge explosion in virus titers, and over time, as your host immune system responds and has the time to build an antibody response to it, your IgM goes up and subsequently your IgG goes up. Now, a couple of questions that come up quite often, and I'd like to clarify them while we're here, is there is a fairly big lag period between when the patient has an infection and when the patient develops antibodies. So for this reason, the CDC is pretty stringent in saying that the antibody test results should not be used to diagnose someone with an active SARS-CoV-2 infection. And the patients between day 0 or day 2 and day 8 or 9 will probably be not antibody positive, but will very much be having a SARS-CoV-2 infection. So please do not use this for diagnosing somebody. The PCRs, and we can talk about that more, have a much better way of diagnosing somebody to have this infection. The other question that comes up all the time is, and this can be almost a misconception, is that if you have antibodies, you're immune. I would suggest that we approach that with a lot of caution. We do not know if the antibodies provide immunity yet. The data is not there yet. We do not know that whether antibodies today will still be present 2 or 3 weeks later. So just because one of us has antibodies to SARS-CoV-2 doesn't quite mean that you do not follow proper infection control practices, wear the proper PPE that you would have otherwise worn. All it tells you that you've had an infection and you've recovered from the infection. It does not mean that you have immunity or any protection towards the secondary infection. The data for that is not quite there yet. The second thing that I'd like to cover is the latest data on the first evidence-based COVID-19 therapeutic trial. As you know, this is a novel virus. Humankind didn't know that this existed around 6 months ago, and over the last 6 months, it's, as you saw, infected more than 5.5 million patients, at least. What this brings to the bedside is, when patients are falling sick, all we have right now to do in an evidence-based manner is to provide supportive care, oxygen and on the floors, critical care support in the ICUs. And there's been a huge drive towards finding a therapeutic tool which will alleviate the burden of illness. We'll come to this later, but there's dozens, if not scores, of clinical trials that are ongoing right now, looking for a solution, a cure, or at least a clinical improvement based on a therapeutic intervention. The first one that has shown some improvement in outcomes is the NIAID-sponsored Act 1 trial. It's an adaptive COVID-19 treatment trial. It came out a week or so ago in the New England, and it studies the use of remdesivir, which is an antiviral, versus placebo in patients hospitalized with confirmed COVID-19. Going over the trial design, it was a multi-center, adaptive, randomized, double-blind, placebo-controlled phase 3 trial. Inclusion criteria were adult patients with confirmed SARS-CoV-2 infection and had to have one of the following criteria. Either they had radiologic infiltrates of viral pneumonia or an ARDS pattern, slight hypoxia at least, SATs less than equal to 94%, or they were critically ill in the ICU. Nicely divided up into a trial arm and a placebo arm. And the initial hypothesis was to look for clinical improvement at day 29. And by clinical improvement, we'll come to this in a second, but they had to show improvement in either their oxygenation status or their functional status. So this was the clinical improvement. That was the study endpoint. One was you had to be in the ordinal scales of 1, 2, and 3, 1 being you were discharged from the hospital with no limitation on activities, going back to baseline. Clinical status ordinal scale number 2 was you were discharged, but you were discharged with a little bit of oxygen support at home. And clinical status ordinal scale number 3 was that you were hospitalized, but that was because you didn't have a safe place to go home. And it was mostly a community, you would be a community risk if you were to go home and infect older people, younger people, more immunocompromised people around you. So these were the study endpoints the study looked at. And the preliminary results from 1,000-odd patients with data available after randomization showed that the median recovery time dropped by a good 4 days. and the p-value for this was statistically significant. The mortality had a trend towards significance, didn't quite get there, but there was mortality of 7% in the trial arm versus 12%, around 12% in the placebo arm. Serious adverse effects, 20% in the trial arm, in the drug arm, 20% in the remdesivir arm, but also 27% in the placebo arm. So not a huge difference between those in serious adverse events. So to put this in context, as you can imagine, there has been a huge interest and initiative from the pharmaceutical companies, from the research agencies to look at what actually works in patients who are infected with COVID-19. There are a total of 469 trials that are currently recruiting patients, around 160 of them or so in the US. And this has a whole, a different spectrum looking at every possible mechanism to stop the death and destruction that comes with this virus. So for example, as you can see in this trial, centers are looking at convalescent plasma, whether a patient is recovered from COVID-19, transfusing that to an infected patient would have improved outcomes. A lot of these nitric oxide prone positioning are ICU relevant. There are some trials here that are looking at stopping the inflammatory cascade that this virus brings with it. And just to put that in context, what we saw in the bedside is that around 7 to 10 days after the patients came to the hospital, the patients went through an immense cytokine storm, a huge inflammatory cascade. These were manifested by fever, high heart rates, high respiratory rates, no obvious evidence of infection. Inflammatory markers like CRPs, IL-6s, LDHs were through the roof, and the patients had a lot of hypotension from the vasoplegia. On the bedside, we were trying things to kind of stop the inflammatory cascade, steroids, IL-6 inhibitors. But these are trials that look at that in a more systematic way to see if there is a way to stop the host immune system from responding in such a damaging way. Remdesivir is one of the trials that now have a positive outcome. There are trials looking at the role of ACE2 inhibitors in the pathophysiology and of this disease. So essentially, there is a mountain of trials that are ongoing, and hopefully we'll have something to help us besides for supportive care in battling this very severe disease. I'm going to move on to your questions. I want to reserve the next 20-25 minutes of this session just for you to ask questions on what we've gone through, keeping in mind that the data behind this disease is evolving as we speak. So some of the questions, the answers to the questions might be different, but they'll be based on the best knowledge that we have right now.
Great, thank you, Dr. Mukherjee. That was a great introduction, and yes, we have had quite a few questions, so it definitely, there's a lot of curiosity on this topic. So why don't I start with the first one? Participant Dick asks if there have been studies to show that asymptomatic individuals can transmit, because in HIV that requires a high viral load, and so the thinking would be that the viral load wouldn't be so high in asymptomatic patients. And what are your thoughts on that?
Right. That's a great question, Nick. And that's a great question, not just for us, but also for our public health colleagues where source identification and isolation is such a challenge, especially in a densely populated city like New York. So the short answer to that is yes. There is data from Europe and from the US showing that asymptomatic transmission occurs. Of course, this is in line with the flu and with other coronaviruses where viral shedding happens before a patient can become febrile or dyspneic or short of breath. But yes, there's no question. There has been studies showing that asymptomatic transmission, that is transmission from human to human before the index patient bounce a fever or a cough occurs. The amount of transmission does seem to relate with how sick the index patient is. So it doesn't, so the amount of infectivity is not as high as someone who's on the ventilator or in the ICU, but there is transmission from person to person before someone becomes symptomatic.
Okay, thank you. The next question is from Gregory. When is a 3-drug regimen approach going to be studied, similar to as was done for HIV therapy? And the participant, Gregory, mentions there are inhibitors of type 2 transmembrane serine protein and viral translation inhibitors that potentially could be added to remdesivir for more efficacy. Any thoughts there?
Um, Great question again. The Kaletra, one of the antiretroviral drugs, was studied in COVID-19, and there was a negative trial that came out in the New England in March. But that said, there is a 3-drug study that's ongoing right now, and I believe it's pretty near to completion, looking at protease inhibitors in conjunction with hydroxychloroquine and azithromycin. From what I understand, there is some promise in that, but there are studies looking at a 3-drug regimen as we speak.
Okay. Another participant asks, what is the sensitivity and specificity of the COVID nasopharyngeal testing?
Oh, that's a very good question, and it's a humbling answer. It is not good at all. We have data from China, which has a couple of months of experience more than the US has, but the rough numbers that came up from China show that an NP and an OP swab have a sensitivity of around 60%. A tracheal aspirate gets you to around 70%, and a bronchoalveolar lavage gets you to close to the 90-95% range. So this is where your clinical suspicion and how badly your community, your city is affected comes into play. You should not be making, and this we probably faltered in this in the beginning of our experience here. You should not be making big changes in de-escalating isolation based on a negative test. It has to be in conjunction with the clinical picture, with imaging, with how badly affected your community is, and the test, the nasopharyngeal or the oropharyngeal test adds as a complement to that whole algorithm, but should not be taken in isolation.
Very helpful. Thank you. Okay, Roberto asks about the rates of adverse effects that you may have seen with hydroxychloroquine and macrolide in your own ICU. Did you see much of that?
Yeah, fair enough. So there's some data coming out from New York showing that there is pretty significant QT prolongation. We were one of the trial sites for hydroxy and azithro, as was one of our sister hospitals in the Bronx. The amount of QT prolongation made our electrophysiologists very nervous. When we were recruiting and when we were using this, we were getting daily QT and QTCs. The actual incidence of how prolonged and how frequent the arrhythmias are, we don't quite know that yet, but it is something to definitely watch out for. And there's at least one large observational trial looking from New York, looking at whether hydroxy and azithro, the combination worked. And it was observational, but it was a negative trial. It was a retrospective observational trial, but it was negative. So the risks might outweigh the benefits in this setting.
Okay. That leads into the next question from Imira. What is the most promising therapy under investigation right now for COVID?
So it's good to have at least one antiviral drug that is now shown some benefit. Of course, we need to use it a bit carefully. You wouldn't expect it to have a lot of benefit if it's used 2-3 weeks into the onset of disease. So think of remdesivir as a Tamiflu analog, where it helps you improve with your symptoms if used within the first few days of disease onset. So remdesivir is promising, and it's the only one we have right now to use in an evidence-based manner. I have a lot of interest in drugs that can blunt the immune response. Like I was mentioning, the viral pneumonia affects them early on in the disease, but as they stay in the ICU and go into week 2 of their illness, the viral pneumonia becomes a silent player, and the host immune response, leading to the cytokine storm, caused death in a lot of our patients. So a safe way to blunt that cytokine response, either from an IL-6 or an IL-1 inhibitor, or from the more generic steroids that we could use, a signal of hope in that setting would help us a lot at the bedside.
Great. Okay, the next question is from Kimberly. What do we know about the reasoning for the hypercoagulability in COVID patients?
Oh, that's a great question. And just to put that in context, Kim, you bring up a very good question. A lot of our patients in New York and across the world probably uh, died of venous thromboembolism. COVID is unexpectedly a very prothrombotic disease process, COVID-19. And we were seeing clots in the legs, of course, but clots in the lungs, clots in the venous system very frequently, even on therapeutic anticoagulation. And to couple with that, there have been a fairly high incidence of patients developing arterial clots, strokes, and MIs in the absence of known risk factors. So hypercoagulability is a big issue in patients with COVID-19. Um, a few things that probably contribute to this. One is the inflammation. As we know from the workhorse triad, inflammation and endothelial damage are big players in forming clots, and COVID being such a hyperinflammatory state probably makes that worse. The other thing that's coming from autopsy data, we don't have a lot of autopsy data, but we have a little bit. And what is being shown is that there's a lot of microthrombi in the lungs from the inflammation and so forth. So I would suggest that the inflammation that comes with COVID leads to the hypercoagulability of it. Almost all our patients were on anticoagulation, either therapeutic or prophylactic. But even on that, we were seeing massive pulmonary embolisms despite being on therapeutic anticoagulation. There is a lot of studies going on, and to look at more autopsy data, look at what kind of anticoagulation profiles patients should follow. So more on that to come, but yes, venous clots, arterial clots are a big contributor to death and demise in this population.
Okay, great, thank you. Two questions that are slightly related. One is, have you observed any IV extravasations with remdesivir? And someone else asked if there's any information about a potential subcutaneous formulation of remdesivir in the future.
That's a good question. So no, we haven't noticed any, at least in our center, we haven't noticed any infiltration yet. Thankfully, the side effect profile has been fairly tolerable so far. In terms of the sub-Q administration, I think there would be a huge value add to this so that we can use it in patients who are not necessarily admitted. I don't know where the process in making that formulation is in terms of drug development.
That makes sense. Okay, the next question, someone asks, what is your experience with using convalescent plasma?
Yes, and good question. This is again under study. The logic works that if someone has had and has recovered from COVID-19, the patient would have antibodies to COVID-19 presumably, and transfusing those antibodies in a suitable candidate might protect the second patient. We've used it, thankfully not a huge lot of side effect profile, but that said, it's off-label. There is no data showing that it would work in the setting of COVID-19 illness. So it would be one of the things that you would use either as a compassionate use in a patient who's an extremist, or under the umbrella of a drug trial.
Great, okay. The next question is from Sarah. She asks if you have any thoughts on the 5-day versus 10-day remdesivir data.
This is a very timely question. I think just last night, a New England paper came out that there was no difference between 5 and 10 days. And that said, if a patient was critically ill in the ICU, I would prefer going to the 10-day arm as long as there's no significant side effect profile. But for all comers, and we can send this paper out later, there is no difference in the 5 versus 10-day arm.
Great. Okay, yeah, that was very timely. Our next question is from David. What do you make of the anecdotal reports of patients who've recovered from COVID-19, are antibody positive, and still shedding virus?
Yeah, I mean, these are challenging times. We don't know yet. So let me back up a little bit. So most viruses have an incubation period of say 7 to 14 days. In COVID, there's a little bit of a earlier onset, so around 2 to 14 days or so, and then the patient falls sick, hopefully recovers, and then goes on to continue to go home and recover. We are in most places in New York, we are testing patients at 21 days post their first positive to see if they still have PCR positive from the nasopharyngeal or oropharyngeal swab. Now, if they are positive, we don't quite know if that's the PCR, which picks up dead viral RNA as well, if the PCR is positive from a patient who's been infected, has recovered, is cured, if you may, and is PCR positive because it's still harboring dead virus in their respiratory tract, versus the patient still has active viral shedding. The only way of knowing this would be to do viral cultures, which require a fair amount of infection control practices, a BSL-3 or above lab. And that research is ongoing in some labs. But for now, when we test patients, even a month out after their initial SARS-CoV-2 NP swab being positive, they are still showing a repeat PCR being positive 3-4 weeks out of their illness. And again, while we don't know if that is dead virus PCR RNA being picked up by the PCR versus actual viral replication, we don't know that yet. Hopefully, future studies looking at viral cultures will help define that fact. The dead virus obviously will not grow on culture.
Right. Okay. That's a good point. The next question from Jean: are well-controlled diabetes and well-controlled high blood pressure considered high risks for mortality with COVID?
Yes. So hypertension for sure. I can tell you our experiences from the Bellevue ICU. So the major risk factors for being critically ill were, in our ICU, being male. 72% of our ICU population were male in gender. Being obese, being hypertensive. There is a lot of research going into how the ACE inhibitors and the ACE receptors play into this. So being hypertensive is a big risk factor. Diabetes and having sleep apnea were other risk factors other than that. But yes, so male, gender, old age, hypertension and obesity are big risk factors for a patient to become critically ill and enter an ICU. And then other conventional risk factors like if a patient has pre-existing lung disease, their cardiopulmonary reserve for battling this would be lower. So if a patient has COPD or ILD, advanced lung diseases in those spectrum, they would be more prone to have respiratory failure from this virus.
Okay, that makes sense. Kind of a converse of the question asked before about viral shedding with antibody positivity. Judith asks for your experience on diagnosing COVID-19. She says we have several cases of RT-PCR negative results in patients that have signs and symptoms and even chest scans that are suggestive of COVID-19. How do you characterize such patients in this era?
Very good question, guys. And so this goes back to how sensitive the nasopharyngeal and the oropharyngeal tests are. There is so much that can go wrong, between poor sample collection to not just having a high enough viral burden to be PCR positive. So if you have a patient, so let's take it step by step. If your city or your community is being hit hard by COVID, and that would essentially mean almost all places right now, and you have a patient who has a fever and a cough and either a GI illness or a respiratory illness, that patient should be treated as a patient with COVID till proven otherwise. And by proving otherwise, a negative PCR on an oropharyngeal test at this point means nothing. Now, we've had patients here, and there's also strong data from Singapore that shows that people can be negative, positive on the fourth test, be positive for a couple of times, go back negative and be positive. So the presence of a positive PCR in a patient who has a pretty high pretest probability of having COVID, you should take the PCR test with a huge grain of salt and not make any major decisions. Do not de-escalate your isolation precautions. Don't treat this patient as a non-COVID patient just based on a PCR. The chances are that the PCR would be a false negative.
That's really helpful. That goes back to the issue of sensitivity and specificity of the test. Okay, so Jeannie asks, they are interested to know which clinical manifestation of COVID-19 has surprised you the most.
That's a great question, Jeannie. Thank you. So two things probably. One is the cytokine storm that we were mentioning, where a patient who came into the ICU with COVID pneumonia on the ventilator was improved for the first 3 or 4 days, and then suddenly started going into the cytokine storm, which was manifested by high heart rates, high respiratory rates, vasodilatation, vasoplegia, and shock, CRPs, inflammatory markers through the roof. And despite all our efforts to blunt the cytokine storm and provide supportive care, a lot of our patients died in our ICUs in front of our eyes because of the cytokine storm. This is something that we, or I personally, had never faced before. And the answers that we could provide to questions that the patients asked us in this setting were quite humbling. The second thing, and I think we were taken a little bit off guard because of the data from China, is that the amount of renal failure that we saw in our ICU population was way higher than what we had expected to see. We expected COVID to present as a respiratory failure, a viral pneumonia, ARDS picture, and we were equipped with ventilators and negative pressure rooms and equipment to deal with that. But when we saw that around 40% of our patients required renal replacement therapy, our resources to deal with that had to evolve very quickly. So for example, of our 300 odd ICU patients, around 130 of them were or are still on dialysis. And many of them were on renal replacement therapy through regular dialysis, which in the ICU is very resource intensive in terms of machines and equipment and nursing care. So early on in late March, early April, we switched over to a PD model, a peritoneal dialysis model, which was able to provide renal replacement to a large swath of our population. So and if you probably know this already, but be very careful about the renal failure that comes with this disease. And these were patients who didn't have any chronic kidney disease. These were patients coming off completely healthy from the street who went into horrible renal failure requiring urgent renal replacement therapy. So the two things that surprised us, and we're preparing along these lines for what we think is the inevitable second wave, are providing enough renal replacement therapy options and trying to find a therapeutic tool in being able to suppress the cytokine storm that comes.
Thank you. A couple of questions are related, basically asking about different types of agents, and I'm not sure that there's enough data on any of this, but someone asked specifically about JAK inhibitors or biologics. Someone mentions a study where there seems to be a good effect with hydrochloroquine and zinc and Tamiflu. Someone mentioned another study of Tamiflu and Kaletra. And then, yeah, so maybe if you just have anything to say about those, or if it's really just too early.
No, I mean, those are all good questions. And, out of those 400 odd trials that are going on across the world, those are the questions that we hope will have answers very soon. So for example, regarding the biologics, rituximab is being studied, olocumab is being studied, cetuximab, IL-6s, toci. We've used toci in a compassionate use basis, and it's being studied in a more scientific manner. So definitely, and I think there is a big role of biologics in trying to suppress the cytokine storm in terms of targeted therapy. In terms of hydroxychloroquine, I'm a little bit more unenthusiastic about that, given what's going on in terms of the side effect profile and at least the observational data coming out of New York. But at least the biologics might help. Tamiflu is being looked at, as is other antivirals. I think over the next 2 or 3 months, and I hope before the second wave hits us, we have some concrete answers on what works, what doesn't.
Someone asks about, let me get to this question here. Are there, other than the oxygen levels, what are the most important markers of disease severity? Are there any, the IL-6, lymphocytes, CD4, I would ask, CD8, anything like that, that you've noticed that can help you guide how severe the disease is?
Oh, absolutely. So, while COVID pneumonia and COVID ARDS starts as a respiratory failure, as a hypoxic respiratory failure, a lot of our patients quickly progressed to multi-organ failure. We're now surprisingly seeing, so in New York, we're seeing in children the Kawasaki profile, the multi-system inflammatory system response in kids. And we're seeing very new to us is the Kawasaki disease profile affecting adults as well, where patients go to the cath lab with a STEMI equivalent and have clean coronaries and myocardial ischemia. So the cardiac profile is a bit different than conventional viruses. A fair amount of transaminitis, like I mentioned, a fair amount of renal failure comes with it. So the three broad spectrums would be, hemodynamics, renal failure, and respiratory failure.
Someone asked, based on this high thrombotic risk, are you using anticoagulation, at therapeutic versus prophylactic dosing? And that also raises the question of, are you waiting to see that patients are having symptoms of that thrombotic effect, or is it just being given more universally when someone's diagnosed? How's that being managed?
That's a great question, Jen. And before I go to that, can I answer? Paul just asked me a question. Did you just say that a second wave is inevitable? Is that specific to New York, or are you referring to the US as a whole and worldwide? I'll just answer that quickly because I think I should clarify my perspective on that. I was talking about mostly New York, guys, simply because, as most of you know, New York is a really densely populated place, as is most places of the world. But New York has certain uniqueness to it. For example, the tight public transport system, that the immigrant population that has poorer access to conventional healthcare, which makes it very prone to getting a pandemic go rampant like this. When I mean a second wave, when you look at antibody tests across the city, it's barely 20% across the city. And the conventional numbers for getting herd immunity are close to 70 to 80%. So while I hope that we don't have a second wave, and we've seen the ugliness of this disease only once, we are preparing and very cognizant of the fact that as the social distancing parameters liberate, and they have to at some point, and people become close to each other in businesses and restaurants and whatever, the virus, which is in the community, spreads again. So while I hope we don't have a second wave, we're preparing and anticipating one, especially in New York City. To the question of anticoagulation, like we mentioned, patients are really prothrombotic. A lot of our patients are so sick in the ICU, and infection control parameters to get them a formal CT angio of their chest were so laborious. We were starting therapeutic anticoagulation based on the D-dimer profiles. So almost everybody was on prophylactic anticoagulation with Lovenox or heparin, but if the D-dimers went up to above a certain level, we arbitrarily called it 4,000 and above, or if we had evidence of a objective clot, we moved over to a therapeutic anticoagulation arm with either Lovenox or heparin. We held off on the NOACs.
Okay, I think we probably have time for one or two more questions. So this one is a follow-up of the question about diabetes and hypertension. I think the person just wants to make sure that you're saying that there's still risk factors, even if they're well controlled with medication. You're still seeing.
Yes.
Yeah.
Yes.
Okay. I thought so. Okay. So how about one more question? This one is from Henry. What role do children play in the spread of COVID-19? And in general, do you have any ideas about why they, generally speaking, aren't getting as sick?
That's a good question. We don't know. There have been, thankfully, less children, and especially less children in the ICUs than adults. There's not a clear understanding, but it might have something to do with the ACE receptors and the fact that they're not as mature in children as they are in adults. What's affecting children in New York now is that Kawasaki profile that I was talking about, but the actual COVID ARDS part didn't seem to affect them as much. And the thinking from my pediatric colleagues seemed to be because of the ACE inhibitors that are not as well developed in the kids as they are in adults.
Great. Thank you very much, Dr. Mukherjee. And thanks to listeners for joining in. As a reminder, to view the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Thank you.